All right, welcome. Today we're going to talk about the physical exam of a spine patient. And we have the beautiful Crystal Walter is going to be our patient. So the first thing, Aaron, what do you do when someone walks in? What do you do when you look at a patient? Is anything going through your mind?
When they first come in the room, watching them walk in.
Yeah. So I watch them carefully when they walk in. So Crystal, why don't you come in, start from the door, or just walk here. Just do a catwalk like a model. Okay. So how would you describe her gait? Keep walking back and forth like a soldier. How would you describe her gait?
She's normal, heel to toe reciprocal. It's a
Keep going. Keep walking.
Describe the base, the
Keep walking. Don't stop.
gait, the stance time.
Yeah. So how would you start her cadence? So cadence is the speed. Well, how would you describe her cadence? Hey, Dr. Pirro, come in.
How you doing?
Good. Today we're doing physical exam.
Huh?
Today we're doing physical exam.
Oh, okay.
Welcome. Come in. Have a seat. Have a seat, please.
See you for a while.
I know. So
My schedule is long.
no problem. Have a seat. So the cadence is
Outside car.
so the cadence is normal. So if they walk really slow, a lot of people walk really slow. Like what are people that walk very slow? Patients that walk very slow.
Older patients.
Older patients walk slow because naturally you walk slower. And so if you see an older person walk fast, it tells you something too. They're very agile and in good shape. Parkinson's, okay, people in pain. So how would you so let me do the gait now. How would you describe? There's a lot of different gaits. How would you describe this gait? Put a focus on the foot.
So,
It's a foot slap gait. So you need a very strong, when you walk and you put your heel down, you need a strong anterior tib to hold your foot up like that. If you don't have a strong anterior tib, what nerve root's the anterior tib? Tibia L4. Should be L4 to L5. So if you don't have a strong one, you do this. But it is strong enough to clear the ground. But it's not strong enough to hold it up. So it's somewhat weak. Now here's another gait. How would you describe this gait? There's a volunteer that walks like this at the hospital.
Drop foot.
is
You
it
can
the-
call it, you can call it drop foot. Drop foot gait's good. What's another way to call it? High steppage gait. So the reason why they do that is they do a high steppage gait because if they don't do a high steppage gait, then what do?
They trip.
They drag their foot like this. Now what is that gait called? It's a foot drag gait. So what does that tell you if someone drags their foot?
That's L5.
L5's out, but what else is out? Why don't they do the high steppage gait?
Oh, they're L3, 4. Would be quad.
Yeah, either their hip hurts or for some reason they can't flex their hip. Okay, here's another gait. Tell me what this gait is.
I don't remember what it's called.
What does this patient have?
Hip.
Did you get that, Brian?
I did.
It's called a circumduction gait. And why am I holding my hand like that? Because I've had a stroke. So the arm is weak, the leg is weak, and the leg is not strong enough to lift up like that. It's just strong enough just to swing it around the side. And why do they swing it around the side? Anybody can guess? Same reason the high steppage gait. So they don't drag their foot. So when they step, if they didn't do that, they'll just drag their foot. So they figure out if they can just whip it around, they won't drag their foot. So that's what patients do when they have a stroke. So you don't see that if they're sitting in the exam. They may have a subtle gait abnormality. You're not going to see that unless you see them walk. Right? So what other gait? You'll never see this, but kids do this. What kind of gait is this?
Oh.
It's not a drunk gait. After 12 beers, what are they lacking? What do people lack? Other than being completely drunk, what do they lack when they do this? What are they missing? Why are they doing this? You won't see this in an adult. You see it in a child, though. They don't have gluteus maximus. So if they don't have gluteus maximus, what they're doing is balancing their body backwards a little bit because their buttocks not firing. and that's how they're walking because their buttocks can't be used to fire. So they have an L5S1 palsy. Children with myelomeningocele walk like that. What happens in adulthood? They don't do it. Adults just give up. They fall. They don't have it. Okay. This gait you'll see in the mall a lot if you look. What is this? What is this gait? You've never seen that before?
Never seen that.
You don't know what it is. That's why. Let's do it again. Ready? Well, what is this person missing? Why are they doing this? It's a quadriceps deficient gait. So if you don't have a quadriceps and you step on your leg, you buckle. The knee gives out. So what people do without a quadriceps is they put their hand down so their knee doesn't give out. They walk like this. You'll never see it in the United States because they wear braces and they just maybe have a surgery, or you'll see it look carefully in the mall. You'll see some Indian people with it, and the reason why is they've had polio. So you'll see that. I've seen that before. I think that's pretty much all the gaits. Okay, so cadence, and the other. How about this? So this is another gait. Ready? Somebody walks in like this. Huh? What is that? Have you ever seen that? You've seen children like that, right? What is that? It's called the scissoring gait because the feet scissor. So, and that's from spasticity. And they've had usually a brain injury in children. And adults, again, don't do that because they just give up walking. They're like, forget it, I'm not going to walk. But kids walk. Another gait, how would you describe this gait?
Short stance, wide base.
Slow cadence, right?
Slow cadence.
And who walks like this? What are you thinking in your mind? Well, they don't have balance. They're ataxic, so they walk with. So if you're totally drunk, you go like this, because you're ataxic when you're drunk. But when you have a spinal cord problem, you can't walk well, so you walk like that as well. So how about this? How would you describe this gait? You see this all the time, right?
Bent forward, short stride.
Yeah.
Slow cadence.
Who walks like this?
Lumbar
Have you ever seen anyone in a grocery store like this?
Lumbar stenosis.
All the time, yeah. So patients with lumbar stenosis, right? They walk like this, and they grab the cart because it's tiring to walk like this. So they just hold on to the cart and they just live like this. Some people just live like this. I saw a guy at the Home Depot. He just carries a cart all the time. He just walks around. He works at the Home Depot. He just has a cart all the time. He's got untreated lumbar stenosis. I didn't say anything to him because I just needed like a screwdriver or something. I was like, you need spine surgery? I was going to give him my card, but I didn't. Okay. Can anybody think of any other gaits that you've seen? So
There's one commercial on TV. It's husband and wife, and they look like this. Over to the right. Both of them. I don't know what it is. They go to the right. I mean, it's a couple.
Well, there is a gait like that. There is a gait like that. That's a non-reciprocal gait.
Always I wonder what's wrong with them. They go
You know
right
why?
way.
They probably. Well, I don't know. That may be weird, but if you have a contracture of your ankle, if you have a plantar contracture of your ankle, an equinus contracture, which you can get from a palsy or a problem with your ankle, you can't do a reciprocal gait because your ankle will not bend. It will not bend like that. So you can't do a reciprocal gait because your ankle doesn't bend. So what some people do, they just walk like this because they're keeping their ankle plantar flexed. So they're not a reciprocal gait. You don't see these commonly. Okay, so gait tells you a lot. What else do you do in exams? Let's go back to Crystal now. Let's say Crystal's the patient. So how else would you examine patients?
Is it heel to toe? Do a heel to toe gait?
Yeah. Good. So the way I describe it is a heel-toe straight line gait like a drunk driving test. And the other thing I do on exam, I don't know what you do, but I tell patients just do what I do because sometimes it's hard to explain to people. So if you just do it, and a lot of times they think they're testing. A lot of times patients say, "Do you think I'm drunk?" And you say, "No, that's not why I'm testing. I'm testing you for spinal cord function." So you just have to tell them because they don't get upset for some whatever reason. So if you can walk a heel toe straight line, what does that tell you?
Your balance, coordination.
It's very good. Yeah. So what else do you have patients do?
Walk on their toes.
Okay. Okay, good. So Crystal can do it. Now, what do you need to be able to walk on your toes?
L5.
Oh, you need an L5, mostly S1. So ankle plantarflexion is S1. You need a strong one. So let's say someone can walk on their toes, and yet they say, I still feel my calf is weak. How can you test that?
Have them stand independently.
Yeah. Let's see if Crystal can do it.
On one
On one
foot
toe.
and
So
then
go
the
up
other.
on one toe. So
Yeah.
lift one. The way I say is I lift one leg and go up on your toe. Now if you can do that's hard.
Balance.
Huh? Can you do it? That's hard. You need a lot of strength to do that. So how about you have a kid who has a young man who's got a problem. He's like a college player. He's like, something's wrong with my ankle. Something's wrong with me. I feel weak. How can you test if he's weak?
Do you have them jump? Or
You can jump on one toe. You need a lot of strength for that. And the other thing you can do is, if it's a relative weakness, you do repetitive testing. So say do it 20 times. To see if they can do, on the one side they can do it 30, on the other side there's like, I can do 10, that's it. So, I mean, it's a relative weakness. So you can test by repetitive testing too. See, same thing in the arms. So you can do repetitive testing for people to see how strong they are. So we said, so walk on the toes, what else?
And then walk on heels.
So what can Crystal do it?
I can do it with heels.
Okay, yeah, she can do it. If you walk on your heels, that's even better. Don't break your heels. So what do you need to do to be able to walk on your heels?
Finally, my L5.
L5, yeah. And L4. Remember, we said some L4 and L5. The book answer is L4 for dorsiflexion, but a lot of people have L5 as well. Is there anything else you do in a standing position for a spine test?
Touch their toes.
Yeah. So Crystal's very flexible. See that? Now the other thing you can do when they peach and touch their toes, you look at their spine. So the other thing is hold on, don't do it just yet. The other thing in the spine, this is out of order, but the first thing is just look at somebody. So can you turn around? So you just look backwards, and then girls tell them to move their hair. Move your hair out of the way. So put your hands down. So the shoulders are symmetric to the floor. Like if a girl has scoliosis, or a boy, they look like that. It's very subtle, and you don't realize it unless you look. The other thing is the hips, the top of the pelvis. Excuse me, touching there. And you can put your hands like this to feel the top of the pelvis. And if someone's one leg is longer than the other, one hemi-pelvis is longer than the other. So orthopedic surgeons, the way you see if the leg length discrepancy is you go behind and you see if one hand is higher than the other when you touch their hips. The other thing is she has a normal contour. See how she has a normal contour like that? And Crystal's thin, so you can see it. But usually girls with scoliosis are thin. And she has normal contour. Now, if she had scoliosis, she would have lost that. And that's a problem if your body is asymmetric. Alan, come in. So we're going over the spine exam today.
What? Sorry?
We're going over the spine exam. We have coffee.
Oh, good.
Sit wherever you want. There's chairs.
All right.
Now the other thing, you look at the side view, and the side view, she's totally normal posture. So what is the spine posture? In the lumbar spine,
Lordosis.
you have lordosis, and what do other people call it? Like layman, sway back?
Sway back.
Lumbar sway back. And then here, thoracic,
Kyphosis.
and cervical,
Lordosis.
lordosis. And the other thing is if you drop like a spear down the center of someone's head, it should be over the pelvis. So if people are imbalanced, like an older person, like they're like this, or a person with a flat back deformity, they're like this. And sometimes people have a really rounded thoracic spine from a fracture, then they have to do a lot of lordosis to the back, and they're in a lot of pain. So the other thing is look at a side view and see what they look like. And when you do that, when you look at people, you got to tell them, let me look at the alignment of your body, because they'll think you're weird or something. So you have to explain what you're doing. So the other thing is when you touch your toes, you look at the spine. So can you touch your toes? So she has no scoliosis. See how it's straight? Now when a person with scoliosis, the ribs, if it's a thoracic scoliosis, is higher. And you measure with your fingers how high. They have like a rib hump. And they can have a hump here if it's lumbar. Okay, that's good. So anything else? So I think that's pretty good from the standing position. Okay, so let's say, why don't you hop up there? How else would you examine her body? Let's say her chief complaint was neck pain radiating to her thumb.
You would want to check range of motion.
Go ahead, why don't you do it? Yeah.
So range of motion of her neck. So can you flex chin to chest?
So how would you describe that flexion?
She's.
How far down can you
There you
go?
go. She can go fully chin to chest, but if she couldn't, you would measure it with finger breadths.
Yeah, that's what I do. Now there's no right or wrong answer. You do whatever you think is right. I just made things up as I practice. And how would you measure extension?
Have her lift all the way up.
Right. So Crystal's like a child. She has full range of motion of her neck. And a child can, the mandible, look at her mandible. The mandible's almost straight up. So she's got a lot of extension. Most adults can't do that. Alan, how much do you have? You're cheating.
You keep your shoulders.
You're cheating. Oh, do it again. See, that's an adult, that's it. He's got 45 degrees. And me, I'm 47 years old. I'm like right there. I have a hard time doing the
Take
paddle
an
because
older one.
I don't have a lot of extension.
Take an older one.
Yeah, but he's immortal though. He doesn't count. Dr. Peter is immortal. He's one of those special human beings.
And he's Greek as well.
Yeah, he's Greek. Yeah.
All right, and then
Okay.
you check rotation right to left.
Yeah. So that's rotation.
And again, and how many degrees of rotation?
So what do you tell patients? I'll tell you. What do you tell? I tell patients just do what I do. Rotate like this. So to make it quick. Yeah. So she has full. How much rotation does Crystal
She's
have?
90 degrees.
Maybe even a little
virtually.
more. She's a little bit like an owl. She can almost look backwards. So what else do you check?
And I volunteered for this.
Her upper body strength. So never put her arms
One more.
up.
There's one more emotion that's. It's not always necessarily bending, and that tells you.
Ear to shoulder.
Yeah. Go ahead. Make your ear touch your shoulder. So she's got a good amount of bending. See that?
Yeah.
So Crystal's a good. She's like childlike in that. Now, who can't bend at all? She's like, oh, ow! Who does that? People with foraminal stenosis. So when you bend your neck like that, you pinch the foramen. So if you have a compressed nerve in the foramen, they just won't do it. So how about you know what Sperling's maneuver is? So the best way to compress the foramen is you tilt your head like that and rotate like that, and that should compress the foramen and give you pain running down your arm. So it's called Sperling's maneuver. It was described in the Journal of Obstetrics in like 1934, but back then that was the only surgical volume, whatever, that they could publish. But everybody does it different, so I don't think it matters too much. I mean, some people compress the head. I don't like doing that because it's very painful for these people and they're scared. So the last thing I want to do is, as a doctor, is hurt somebody because they'll get upset. So I tend not to do these procedures.
And most patients complain about pain on any of the first four motions.
Yeah, and if they tell you when I move my neck, it runs down my arm, that's good enough for me, and I stop right there. I don't torture people. Okay, so bending. So how do you check strength? So remember, the chief complaint is pain running into her thumb. So if someone says, my thumb is numb, pain runs into your thumb, what are you thinking in your mind?
C6 nerve root.
C6 nerve root, right, so C6 like that. The other thing is, when patients say my arm hurts, the typical thing patients say is like, my arm hurts, but does that give you enough information? Just chase point left arm pain, what do you want to know?
If it's coming from somewhere else, so does she hurt anywhere else? What types of motions make
so
it
it doesn't
hurt?
run anywhere else. So what provokes it, palliates it, the quality of the pain, sharp, dull, fiery, the region, the severity, and the timing,
Right.
PQRST. And I have people stick a finger and point to where it hurts. So if people have a discrete dermatoma distribution, they will track the whole thing out. They will show you exactly where they feel it. Now, if they do not have a dermatoma distribution, they just sort of like wave, which tells you something, right? Okay. So how do you check strength?
So upper extremity motor strength, and ever put her arms up, don't let me push you down.
Okay. So you're testing deltoid, right? So
Right.
you're testing shoulder abduction, which is mostly the C5 nerve root when you do that. Okay.
And then have push me away.
Okay. So you're checking triceps. Okay, that's a good way to do it. Another, you can do it other ways too. Is you can say push against me and
Sure.
push against me and go all the way to the extent. Do it again, and you get sort of a better feeling. You compare both sides. And if someone's let's say it's Ray Lewis, How are you gonna test Ray Lewis?
I'll call you.
You can do it. You can do it. How do you test Ray Lewis?
You would have to test him independently.
Well, would you test him like this, all the way down? Now push as hard as you can. I mean, Ray Lewis will have a little bit of a hard time if you go all like that and pushing as hard. I mean, Crystal can't overcome it. Go ahead, Crystal.
No, I can't.
She can't. It's hard. Actually, see if you can stop me. All the way
Which way
down.
am I going?
Put your hand back there
Back here?
and stop me from bending it. Ready? Go. No, I can easily do it.
Yeah,
Again.
you can.
Well, maybe Ray Lewis, you have to calm down. But you can like put your whole body weight so, and then have Ray Lewis do it 10 times. But that's the problem with football players. They're hard to examine because they're just so strong, and they're a relative weakness. But you can have him do like one arm push-ups, or you can fatigue him, so he can tell you how strong he is. Okay, so we did C5. What else? Deltoid. C7 is triceps.
C7. We're gonna have the wrists. So I'd have her flex her wrists, test her wrist strength, don't let me straighten them.
Okay, and wrist flexion is what? C7.
And then, don't let me
Wrist
straighten
extension.
them. It's 8. Right?
C6. C6.
And open your fingers nice and wide. Balance.
You were right. This is
Together.
T1. I looked it up. I thought it was always C8, but it's mostly T1. But the lumbricals are C8. You can do it with a grip strength. So you just what I do is I have 2 fingers and I put 2 fingers in and squeeze as hard as you can. But be careful. Some people try to break your fingers, so you have to be ready for it.
Right, but can't you cross your fingers and then they can't hurt you?
Don't do that with Ray Lewis.
I wouldn't do it with Ray Lewis.
Don't do that with Ray Lewis.
So checking equal grip strength.
Yeah,
What's
and
that?
you can tell grip strength.
Right.
Something else you missed. Did you miss something? I think
Good,
that's it.
we didn't go.
Yeah. Oh, and the other thing is rotator cuff. So a lot of people have arm pain. It's not coming from the neck. It's coming from the shoulder. So the typical subacromial bursitis pain runs from here to here. They always point to their deltoid insertion. So it's very common, and a lot of people have 2 problems. They have C5 radiculopathy and they have a rotator cuff tear. And it's very hard to say which one it is. So how do you test the rotator cuff strength?
Well, first I'd ask them to put their hands all the way over their head.
Right, that's good. That's my screen. Like if someone can do this, their rotator cuff's probably fine. But let's say they just go like halfway up and they're like, ow. Then what else
Halfway,
do you do?
you can have them put your hands together and have them put
External
out.
rotate.
See if they can do that.
The other thing is as you get older, everybody gets rotator cuff tears. Everybody gets subacromial bursitis. It's part of being a human being, I think. So it's very, very common. If you go to the ICU and you examine everybody in the ICU, everyone's got a rotator cuff tear. Everybody. And you'll see the shoulders. You'll see the acromial-humeral distance on the chest X-rays. They're all down to 0 in the ICU because the ICU is mostly older people. They're like 70s, 80s, and they've all lost their rotator cuff. So that's when we were interns in the ICU, we used to always laugh that everyone's got a rotator cuff tear, sign them up for surgery. But that's, we used to always say that, but these patients are asymptomatic. I mean, you can live without a rotator cuff. So I think it's part of the aging process. Okay, so supraspinatus. I mean, that's infraspinatus. So external rotation, elbow at the side. So shoulder external rotation, elbow at the side is 85% infraspinatus, apparently. So how do you check supraspinatus?
It's the thumb down.
Thumb down, yeah. So I call it thumb down forward elevation. Go ahead, test the thumb down forward elevation.
Am I supposed to do? Is it resistance?
Go up to the ceiling, yeah. Okay, and that tests supraspinatus strength. Supraspinatus. So the first part of the rotator cuff that tears is supraspinatus, and the second part's an infraspinatus. If you have an infraspinatus tear, you've got a really big one. So the more sensitive test is this, and this shows you like if you have a big tear. But also people like this, if they may have bursitis and they may not let you do this because it hurts. So if they could do this fully, I mean I have a little bit of subacromial bursitis. It hurts a little bit, but not a lot. But my strength's pretty good. Okay, so the shoulder, and you also should probably do a shoulder exam, a full shoulder exam. You want to do it, or you want me to show you? Okay. So I'm not a shoulder surgeon, but I need to know, as I go to neutral, I text external rotation, internal rotation. And then very simple things, I say, how far up can you go on your back? So how far up can you go on your back? Okay, so she's extremely, turns to a camera. She's extremely flexible, so she can go all the way up there. And then I'd say touch the back of your head, that shows you external rotation. So the key things to the shoulder is you want to be able to take care of your hair, comb your hair, and eat. And you also have to wipe your backside when you go to the bathroom. So those are the very key things you need as a human being in the shoulder. Those are the basics. And then check abduction, and that if they have a AC pain, they hurt there, and also palpate the AC joint to see if that's tender. So those are kind of like basics for the shoulder. And then the other thing is people have concomitant neck pain and shoulder pain. So the way I differentiate it, as I say, when I move their shoulder like this and go up, which is the impingement test, does that give you your pain? And they may say, no, that's not the pain. And then I move the neck, and I say, is that cause your pain? Say, yes. So that's sort of like how you can tell the difference between cervical pain and shoulder pain. Okay, so what else do you do on exam? Oh, we didn't get a Brigham Mallet.
Yes, we did.
You did? Oh, good job. So check the reflexes?
Yeah.
You do it.
I have hard reflexes.
So besides reflexes, you want to check sensation. So
Right.
asking if does it feel the same on both sides in all parts.
So you're just doing light, you can
Light
do light touch, you can also do pain with a needle. I mean, I usually don't do pain.
Right.
And, go ahead.
And then, so reflexes, you want to check Hoffman's. Would you check
Okay.
that first, or would you do the
You check
other?
off, yeah, Hoffman's.
So, hold the middle finger, holding the joint. Middle finger, your hands are so
Yeah.
joined. And you're looking for a response.
Right, so do mine, I'll show you the response. So, well, I would hold this one still, and then do just, so if people do that, so we show, so do it here. So hold them, go to show on here. If they do that, they have an upper motor release, they have spasticity. So if you flick that, and the finger goes like they're spastic. The other thing is inverted radial nerve reflex. So normally when you hit the radial nerve, it goes up, but if it goes down, it's a sign of spasticity. What other sign of spasticity is there?
Clonus of the ankles.
Clonus of the ankles, yeah. So when I see if Crystal has clonus.
So just relax your foot and let me move it.
Okay, and when I do it, you get a lot of practice in peds because you see a lot of children that are spastic. Usually, most adults aren't spastic, but you get better at peds. You hold the leg still and you lift it up and you hold it up. And if they have spasticity, when you got to hold this well. And if they have spasticity, you keep the pressure up. You don't just go up and down. You keep the pressure when you do it. They go like this. They shake. And if you keep the pressure on, they'll just keep shaking forever. And then that's a lot different than just a couple beats. So a couple beats of clonus, kind of normal. People have sustained clonus, definitely not normal. Now let's say if they're in between. Yeah, it could be spinal cord too. So when they have beats, I also count it. So I was like, oh, this person's not sustained, and yet that's not normal. So I say 10 beats of clonus, which is not 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and it stops. That's not normal, and yet it's not sustained clonus. But you're suspicious. Okay, so what else do you do? We did sensation. Let's do reflexes.
Reflexes. So you
can do this. Come on.
Biceps.
Okay, so how do you do biceps? Okay, you do it with your fist. I usually use my thumb.
Do you?
Yeah. So put your thumb on the tendon, but put the pulp of your thumb on the tendon. Can you feel it? You feel it. You can feel the tendon now, right? Now hit your thumb. Hit it with the same. Yeah. There. See? That's good.
You got it.
See how easy it is?
It is.
Yeah. So I put the pulp of my thumb on the tendon, and you can always feel the tendon, and then hit your finger. Yeah. Good. And you see it fire.
And then brachioradialis.
Brachioradialis goes like right there. Let's just show you. Brachioradialis goes right there and ends right there. So we're gonna hit it like in the tendon thing. Or you can just hit her. You don't need to. It's kind of easy.
Point.
She's got it. That's good. She doesn't see it. That wasn't really good. I do like this.
What do you think?
The brachioradialis muscle. She like goes up. You go like that. See how she goes up a little bit. She doesn't have great reflexes. Okay. Triceps.
Tricep.
Mm-hmm.
Do you have her hang? Do you use your thumb on her?
No, it's to the tendon. Pretty good. You see? So the other thing is I tell people just relax. When I do reflexes, I ask some silly question like, Who do you think is gonna? I'm gonna ask you a question. Who do you think is gonna win the Ravens game?
Better be the Ravens.
So she's thinking about the Ravens, and then you do your tendon. So that's what I usually do. I talk about the Ravens, or in their social history, I ask them, like, does your son live local? And then they start thinking about their son, and then you get the reflexes. How about the reflexes in lower extremities?
So,
I have that.
you always stand to the side, most of our
Because they may
patients don't
kick, yeah.
necessarily, but,
Yeah, there, she's got patella tendon reflex.
and then you can do the
Achilles tendon.
Achilles
I had
with
this
her
on.
boots on, probably not, but right
So,
here, hold it.
So,
Go ahead.
quadriceps is L4. We didn't say what number. This is biceps is C5. Brachioradialis C6. Triceps is C7. Okay, quadriceps is L4.
Four.
And what are
Achilles is
Achilles
one.
S1. Do you know the secret patella? You know the secret one for L5?
Isn't it,
Posterior tib tendon.
posterior, yeah.
You know how to do it?
Mm-hmm.
Okay. Posterior. Can you take off your shoe? Actually, can you get the other one off? I'm sorry. I hope you have clean socks.
I do.
I'm just.
But there's.
So the posterior tib tendon inserts right in there, and it's hard to get in an adult. In kids, it's easy because they're spastic. But I usually evert the foot a little bit and hit the tendon. See, she's got it. See, she's childlike. See how she flexes. So that's a way to check the L5 nerve root. Now, deep tendon reflexes I found in practice. I hate to say this, they're not too helpful because who cares if you don't have a reflex? Nobody cares. And the patient's like, yeah, docs it because I don't have a reflex. I mean, that's not a reason to do an operation. So they're interesting, but I think in 2013, soon to be 2014, everything's done by MRI. So if you have a lesion on MRI and you hurt, so in the old days we didn't have MRI. So the Hoppenfeld book that you were reading, did you notice they had myelogram pictures? So I was like, what is the myelogram? It's like, this is the best they can do? And then I looked back, it was from 1977. I bought it used when I was a resident to save money. But now everyone gets an MRI. Like Ladarius Webb, limps off the field. What do they say on Monday? MRI is pending this afternoon. So everybody gets MRIs for everything. So basically, neurological physical exam is not as important as it used to be because we didn't have MRIs. This is all we had to understand problems, So it's a little bit of a depressing thought, but the neurological exam has declined over the last 10, 15 years because MRIs are so good. Okay, so it's good. So what about anything else? I think that's about everything. So can you think of anything else? Cervical exam. Okay, how about let's say she has chief complaint of sciatica that runs down to her lateral malleolus. When people say lateral malleolus, what do you think of? The pain. I always say it runs down my leg and say the inside of the ankle or the outside of the ankle. If they say outside of the ankle, what are you thinking? L5 nerve root. If they say medial knee, like inside of my knee hurts or inside of my shin hurts, L4. What if they say it goes all the way to my heel and the outside of my foot? S1. Okay, so those are the typical dermatome distributions or dynatomes where they say it hurts. Okay, how would you examine if they had sciatica?
Do you want to take your other? So I would check her, even though she walked on her toes and heels, still check her strength for ankle dorsiflexion and dorsiflexion. So pull your toes all the way up and don't let me push down.
Okay, so ankle dorsiflexion we said is L4 and L5, and toe dorsiflexion, extensor digitorum longus, extensor hallucis longus is more L5. You can check that too.
Test.
Yeah, and some people have a strong ankle, but they can't lift their toe up.
So just lift your toes.
So she's got strong. Okay.
Then I have her straighten her leg. You put your leg. She can do both. And again, test resistance.
Okay, at end extension, it's hard to break it. So how do you check? That's another way to check quadricep strength.
What is or that
At
is?
end extension, it's very hard. A hand cannot break a quad. You're not strong enough to break a quad. So how else can you check quadriceps strength? There's a couple ways. You can extend against you. So say extend against me. Go ahead, see if you can do it. And usually people should be able to overcome you. And then there's another way you can do a standing on a stand.
To squat.
Squat to stand. So for you to be able to squat all the way down and stand, you need two things. You need very strong quads, and you need to have good meniscus. If you have bad knees and a meniscal tear, you cannot do that.
Or just watching them rise from the chair if they need to use their hands to lift up.
Right, that's a good measure of quadricep strength. So let me show you a patient that has weak quadriceps. You say, okay, Mr. Jones, please stand up. They're like, oh, hold on. They do this. They rock 3 times to get the motion going. They go, whoa, and then they stand. So I put that in my examination. Is like patient. If you tell a patient like, can you stand up, and they go like this, you say they stand independently with no difficulty. That tells you something. Okay. So what else? So quadriceps.
Quadriceps.
Is quadriceps is L2, L3, L4, right? But mostly, probably, I feel in practice, it's L3. So the palsies, the quadriceps palsies that I've seen are from L3 nerve root. So if you have an L4 palsy, people still have a reasonable quad. But that's, I don't know, that's not scientific, that's just word on the street, just from practicing.
Right, hip flexors, they have to look this way. And again, resisting there.
Okay, and hip flexors are what? L1, L2, L3, and it's iliopsoas strength. Okay, and the other thing, you can be fooled by hip flexion because you may have a normal neurological exam and you're still weak in your hip. Who has weak hips but has normal nerves? Arthritic hips. So people with arthritic hips, they get weak hips too.
Right.
Okay, so what else?
One thing we didn't say about here was looking for straight leg raise and pain elicited by that.
Yeah. So that's a straight leg raise is when that makes the pain worse, right? Because you tent the nerve, and also extend the ankle. That extends the nerve. That pulls the nerve just a little bit more. And some people call it Lasigue's 1 and Lasigue 2. Lasegue. Lasigue 1 is just straight leg raise with the knee. Lasigue 2 is with the ankle. Okay.
So you would.
And the other thing, the other way to call that is nerve root tension sign. So if you think that the pain is not coming from nerve root tension, you just say nerve root tension sign's negative.
So we were just talking about the hip. If you lift here, whether she might have good strength, but you can still check internal and external rotation.
You see,
So rotate in.
Yeah. And ask them where's the pain. So hip pain can radiate to the back, but it usually radiates to the groin. So you can differ. And also hip pain can radiate to the thigh, to the outside of the knee. So a lot of people come to the spine patient because they have pain in the thigh that runs to the knee. Some people even have knee arthroscopies because they have hip arthritis. But if you carefully examine the hip and you notice it's stiff and painful and radiates to the knee, then that's a hip problem. So the hip can refer to many different areas, just like the heart. It can refer to the lower back, and usually it's the groin, but also refer to the thigh, to the outside of the knee. It's because it's in the same dermatoma distribution as the obturator nerve. So that's the distribution of the obturator nerve. So the signal goes to the brain, and the brain just says, obturator nerve pain, which is usually groin, but sometimes it's other areas. So it's kind of interesting, right? The afferent's the operator nerve, obturator nerve, but then where it's registered in the brain can vary. So it's interesting. So what else? What else did you do? How about, you ever do popliteal angles? Popliteal angles are usually in kids. So can you lay flat? So you can also do a straight leg raise in the supine position. That's what most people do it, like old school physicians when they had a long time. So she's totally naked. But put the other leg down. Now do it. So that's just 0. It's very. I'm about 90. So once you get up, I'll show you my popliteal angle. Is as you get older, you get stiff, and my popliteal angle is that's about it. It hurts right there. So I'm like 30. So that's a measure of stiffness, and also that's a nerve root tension sign. Okay, I think. Is there anything else? Did we skip?
Just sensation to light touch on lower extremities, just like upper.
Yeah. So the sensories, the groin, just in the chest. We almost never see it as an outpatient because usually it's a spinal cord injury. But the nipple line is 4, the top is T1, the nipple line is T4, the umbilicus is T10, and just above the inguinal crease is T12. So spinal cord injuries, we say like someone's a C5 spinal cord injury, that's the first normal level. So at C5, everything works, but something's wrong at C6. So that's why in the thoracic spine, it's important to know what's the normal first sensory that's normal, and they can tell you where the injury is. In the lumbar spine, just below the groin is L1, L2 is in the middle of the thigh, L3 usually radiates to the outside of the thigh, in front of the knee. L4, where does L4 go? Remember, it's the medial knee, medial shin, medial ankle. L5, lateral ankle, dorsum of the foot. S1,
Lateral foot.
lateral border of the foot. S2, S3, plantar aspect of the foot. Now, so, anything else on exam? So there's another thing that we're obviously not going to talk about with Crystal, but is sacral nerve root dysfunction. So let's say someone says, how do you do a rectal exam? Do you remember? Or do you want me to do it? To say how to do it?
You have them lay on their side.
Yeah, lay on the so the key aspect of the rectal exam, you have the patient lay on their side. And this is just how I do it. And when you do a rectal exam, you point your finger towards the umbilicus. Otherwise, it can hurt. So you obviously don't want to hurt somebody. Now, you want to check anal sphincter tone, because the only thing we have to check the sacrum, to check sacral nerve roots S2 and S3 and S4. And you may say, well, why do you do this? Just leave the person alone. Well, if the person loses their bowel and bladder control, serious problem. So you got to know if it's happening. So the anal sphincter has two sphincters. I could just do it in my hand. So I'll say this is the anal sphincter in my hand. The outer one is the hold on, I get these mixed up. The external sphincter is the voluntary tone, and the internal sphincter is the involuntary tone. So there's voluntary tone to the anal sphincter and the involuntary tone. So the involuntary tone is always working in everybody, because obviously we all, we're not fecally incontinent. So it's always working. But sometimes, let's say you're just about to have a bowel movement, the fecal matter presses on the involuntary sphincter and may start to come out, and then your external sphincter works. And the external sphincter, you can control that. So the good physical exam is you put your finger on the anus and go real slow and say, can you feel that? And some people say, I don't feel anything.
Don't you touch on the outside?
You can also touch the outside. So the outside is like S3, the more inside S4, and then the very inside of the anus is like S5, like ballpark. So if you touch, can you feel that? And it's like, no, like a serious problem. So that's perineal anesthesia. So you put your finger, and then you put your finger in. The first one should be loose, unless the person's contracting because they're nervous. So try to relax. Obviously, it's a terrible thing to do to somebody because it's uncomfortable. So the voluntary one should be loose, and then you go in, and you should always have some involuntary tone, and you should feel it. You should feel you go in. There's something there like squeezing on your finger, and then with your finger in there, you say, "Squeeze on my finger." Try to squeeze on my finger, and they may say, "I am," and you don't feel anything. Well, the patient has no voluntary tone. The external anal sphincter is not working. So that's the two different things you should say in your rectal exam. So you should point to a sensation. External anal sphincter and internal anal sphincter. You can say voluntary sphincter tone, involuntary sphincter tone. So they have nothing, and they have totally no sphincter function whatsoever. It's a big problem. So this happens in like cauda equina syndrome. There's a couple other tests. Do you know about the I forget the name of it. The way to test spinal shock. We won't get into that. Huh? All right, we won't get it. So I think that's it. Anything else you can think of? The only other thing we can talk about gait was the Trendelenburg gait, which is my favorite gait.
Why don't you model it?
Huh? Yeah. So Trendelenburg gait's really important because a lot of people have it. Because people have L5 palsies. So Trendelenburg gait. The other thing you can do in kids and adults, you say lift up one leg. If they don't have an L5 nerve root, their hip goes down. So you say lift up one leg, they go like this. And I can't do it. So the hip abductor here fires when you lift up a leg. It keeps you standing. If you don't have this muscle here, your body goes like that. So as you lift up the leg, they go like that, and they fall. And then when they walk, they go like this. Some people. Now, the people who walk like this, they're very weak people. Like, they're so weak that they're not even compensating. So they may be mentally weak, they may be sick or ill, they may be very, very old. They're not even compensating. Now let's say you have a strong person with no L5 palsy, they're not going to walk like this because they want to walk, you know, they want to move. So they go like that. So they figured it out that if they just center gravity over this leg, they compensate for not having a hip abductor. So you'll see if you look carefully, you'll see people in the grocery store all the time. They walk like this. They're fine. They have no problem. And they don't have a hip abductor. But you can also lose your hip abductor from arthritis. So you see a lot of arthritic people walking like this too, because their hip just doesn't. They've been so in pain for so long, and they've been stiff for so long that they just lost their abductor. So they just always walk like that. And these are normal people. You can have a normal life with a Trendelenburg list. When you're in a grocery store, you see them. That person has a Trendelenburg gait. So whenever I go to the store with my brother, we're constantly looking at gaits. Like I say, John, that person has a Trendelenburg gait. And we say that person has a drop foot. And we were constantly looking at gaits, and we were describing gaits. Okay, I think that's it. So any other questions or thoughts or anything anyone wants to add to a spine exam?
Can you be in a situation where people have stiff muscles and that influences the exam?
Yeah, absolutely, yeah.
You think they have an impaired range of movement or something, or?
You can't examine someone who's stiff. So let's say, are you saying like someone has a painful neck or like a disc herniation or has an injury? You can't examine them. So you just say examination is hampered by the fact that the patient's in pain, so they're stiff. So you don't know what to say. You don't know. It's too early.
You give them a muscle relaxant?
Yeah, you just give. So the whole point of painful conditions is usually this time it just goes away. So give them a muscle relaxer, pain medication. Just get them, break the cycle of pain, get them over this painful time period with the hope that things will quiet down and the disease process will just resolve on its own. Most people have severe arthritic problems. They live their whole lives, don't have any problems whatsoever. They get flare-ups, you just deal with the flare-up, give them some pain medications, non-steroidals, steroids, muscle relaxers, anything, just to get them over this flare-up, and then they're fine. They go their whole lives with arthritis.
If somebody has a primary muscle problem, not just stiff muscles, how's that going to affect your spine exam?
You mean someone like myasthenia gravis or something like that?
Or some inflammatory muscle disease. They can't move because it's...
Like polymyalgia rheumatica or something?
Something like that.
That usually doesn't affect the exam. So you just know they're diffusely weak. A little bit weak.
What about if they're hyperreflexia? What if they can extend, overextend?
Are you hyperflexible? Let me see. Let's see. I shouldn't have said anything. Come over here. So she's a hyperflexible.
So Brian says he is too.
Really? Well, he's a cameraman though. Some people are hyperflexible, so the thing in kids, you see this in kids. See how the elbow should be neutral. See how she hyperextends here, and the other one is in the. Can you go backwards with your knee? No, the other one. Just stand straight.
Okay.
And can you make your knee go back?
How's
So
that?
she's got a little bit of hyperextension to her knee. And the other thing you test for kids is, can you make your thumb touch your elbow? See, she can make her thumb. She's very flexible. She's a hyperflexible individual. So when some people have
Hips pop out too.
yeah, people have hyperflexible people are at risk to develop joint problems because their joints they subluxate, they change. So those are the way. How about you? Do you have it?
No, I'm just not there.
You hyperflexible?
Just me, hands.
Yeah, and some
his.
remarkable.
Look
Yeah.
at Brian's.
Oh my God, yeah, he's very. And some remarkable athletes are hyperflexible. So it doesn't. Yeah, it's just everybody's different. So you find, and the like a lot of pitchers are hyperflexible, and that's a problem because they put so much stress on their shoulder that it keeps popping in and out, and they have a lot of problems. They have a lot of impingement problems, and they have difficulty pitching. Their elbows too. So hyperflexibility can cause problems, but you can be a remarkable athlete and be hyperflexible.
I have to ask you a question about the range of motion of right and left side. Okay, not because I have.
See how
Don't
he's
not asking
squirting
you
his
for-
chin?
No.
Yeah, it is.
No. We used to have, if you have 1 minute.
Yeah, go ahead.
We used to have a German physical, to take us to a gym, all right? And always we used to do this. Then, this thing and the opposite. But when you do right-handed people mostly, feel this, too. The other one.
Yeah, well, you're remarkably flexible.
But this one, if you do it, I'm right-handed, right? But this doesn't touch.
Yeah.
This,
Yeah.
and they used to give us like bowling ball, a bowling, what you call it when you do bowling, those things anyway.
Yeah.
And we'll hold and we do all those things to
Yeah.
make this easy.
Yeah.
They took us outside, to do, some of them hit our heads, of course, because it
Yeah.
was big.
To-
But this one, always, when you do on a patient, they can do one like this, but they cannot do the other.
And which one's
Never
stiff?
noticed this before. I don't know why those two. No, it's just they said, I cannot feel my wing bone or something,
Right.
So I don't know. There is any reason for that? Not it's me. It's me, of course. I'm immortal. You said.
I have to think. I've never heard of this before in my life.
No.
I have to think about it.
Yeah. What it is that you cannot really
Well-
do one side.
Well, the-
Right
Could
hand
be,
and all
I was
that.
gonna say, could it be more dominant?
You mean
Because I'm the
older
same way.
people or kids?
Everybody.
Everybody?
No,
Kids?
Yeah, I can touch
Kids.
it this
Everybody.
way, but I can't do it this way.
Everybody's probably the left-handed can touch the right.
How about the other side?
See that? No,
Yeah,
I
Crystal's
thought-
kid-like, childlike. I don't know.
I don't know.
I don't know. Other than human beings are asymmetric, they all have some mild asymmetry to
yeah.
them. So we see this in orthopedics all the time. I think they measured leg lengths in 18-year-old Army recruits, I think in World War II, by X-ray, and they found like everyone was off by about 3 or 5 millimeters. It's very rare for 50. I think 15% of people were exactly the same. So every human being has a slight asymmetry. Like God doesn't make everybody just exactly
Is
perfect.
the shoulder joint that does
It could
this,
be,
that
yeah,
doesn't
that's-
go so much up?
Yeah. It could just be you're just seeing normal physiological asymmetry, that the design of the human body is not totally perfect.
Just
Like kidneys, one kidney's slightly bigger than the other, or
so
et
many
cetera.
years I couldn't figure that out.
No, I don't know. It's interesting. I'll have to think about it too. I'm not sure what the answer is. What else? Any other questions? Anybody?
How about hyperreflexia? What if you test someone and they have over-exaggerated reflexes?
Right, so the reflexes, if you hit it and absolutely nothing, what is that? 0 out of 4, right?
Right.
And normal is like
2.
2 out of 4. How about you hit it and it just barely hits, it goes up? Just barely? 1 out of 4. 3, 3 is when it's hyperreflexic, and 4 is when there's clonus. So you hit it and it goes back and forth a couple times. So 4 is clonus. So that's how you grade it. Yeah. Yeah, no, you're right. What else? Anything else? We all good? I want to thank Crystal for being wonderfully patient.
Childlike.
Crystal's patient with me every single day in the office, and she helps me with the conference. So she's the best. Okay, that's it. Thanks.